Small intestine neuroendocrine tumors, your complete guide from diagnosis to long-term care. Hello, this evidence-based content is prepared by Saboor Khan, fellowship-trained consultant surgeon, and if you or someone you care about has been recently diagnosed with a small intestine neuroendocrine tumor, or perhaps you've been told you have a NET and you're wondering what this means for your future, you're in the right place. I know hearing the word tumor can feel overwhelming, and you probably have a lot of questions about why these are often found late, what tests you'll need, and what treatment actually looks like. Small intestine neuroendocrine tumors, often called SINETs, are rare cancers that develop from neuroendocrine cells in your small bowel, particularly the ileum, which is the last section. These aren't your typical fast-growing cancers. Most SINETs are slow-growing, well-differentiated tumors classified as either G1 or G2 based on how quickly the cells are dividing. What makes this personally relevant is that SINET is actually the most common type among all gastroenteropancreatic NETs, with an incidence rate of about 1.05 per 100,000 people annually. Let me explain the three main reasons why SINETs present such a diagnostic challenge and why understanding this matters for your journey ahead. Here's the frustrating reality. Most patients with SINET have non-functioning tumors, meaning they don't produce obvious hormonal symptoms early on. Instead, you might experience subtle gastrointestinal symptoms that can easily be mistaken for common digestive issues, some mild abdominal discomfort, perhaps occasional diarrhea, maybe some vague abdominal pain. These symptoms are so nonspecific that they rarely prompt immediate investigation. This is why SINETs are often diagnosed at an advanced stage of disease, either incidentally during imaging for another reason, or when symptoms from metastases finally become impossible to ignore. Only about 30% of patients present with what's called carcinoid syndrome. That's when the tumor produces enough serotonin and other biologically active substances to cause specific symptoms like flushing of the face and neck, chronic diarrhea, and sometimes wheezing. But here's where it gets interesting. Carcinoid syndrome usually only occurs when there are liver metastases present, because the liver normally breaks down these hormones before they can cause symptoms throughout your body. If you're supporting someone through this diagnosis, this explains why they might have felt fine for months or even years before discovering they had cancer. The small intestine itself presents unique challenges for imaging. These tumors are usually small, often measuring less than 2 centimeters, and they're tucked away in loops of bowel that are constantly moving. On standard CT scans with oral contrast, SINETs can be difficult to see. Frequently, SINETs actually present because of mesenteric metastases rather than the primary tumor itself. These metastases induce an intense desmoplastic reaction that's scar tissue formation, causing contraction and tethering of the adjacent bowel loops. This can result in partial or complete intestinal obstruction. Specialized techniques like capsule endoscopy, where you swallow a tiny camera, or double balloon enteroscopy, can identify these tumors, but they're not routinely used because of cost and complexity. The real gold standard remains what happens during surgery: bimanual palpation of the entire small intestine by an experienced surgeon. This is when additional synchronous tumors are often discovered, because here's something crucial to know. Multiple tumors occur in 40% to 60% of patients, and these are usually not detected by any preoperative imaging. These tumors have a remarkable tendency to spread to mesenteric lymph nodes, the lymph nodes in the membrane that attaches your intestine to the abdominal wall. Even small primary tumors, less than 10 millimeters, can show lymph node metastases. In fact, nearly half of patients with SINETs smaller than 1 centimeter already have lymph node involvement. This aggressive lymphatic spread is why all localized SINETs, even when small and discovered incidentally, require surgical resection with adequate lymphadenectomy. That's removal of surrounding lymph nodes. Now, what about mesenteric fibrosis? Patients affected by mesenteric fibrosis have significantly poorer overall survival compared to those without it. The fibrosis can cause bowel obstruction and bowel ischemia, presenting with severe abdominal pain. About 5% of patients develop what's called a frozen abdomen, particularly in the pelvis, where massive fibrotic reaction makes the surgical field incredibly challenging. The extent of nodal involvement and degree of mesenteric fibrosis represent the main determinants of surgical resectability, according to the classification developed by Orval and colleagues, which stages arterial involvement from 0 to 3. Let me talk about the comprehensive diagnostic workup you should expect, because proper staging determines your entire treatment strategy. First, you need biochemical assessment. This includes measuring chromogranin A in your blood. It's the most important general biomarker for most NETs, with sensitivity and specificity somewhere between 60 and 90%. For SINET specifically, measuring urinary 5-hydroxyindoleacetic acid, or 5-HIAA, is crucial. This is the breakdown product of serotonin, and it's an important marker for diagnosing and following SINETs. The overall sensitivity and specificity of urinary 5-HIAA are about 70% and 90% respectively. You'll need to avoid certain foods with high serotonin content before this test, things like bananas, avocados, walnuts, and pineapple, because they can falsely elevate your results. For imaging, the current gold standard is somatostatin receptor imaging using PET-CT with gallium-68 labeled somatostatin analogues, either Ga68 DOTA-TOC, Ga68 DOTA-TATE, or Ga68 DOTA-NOC. These perform similarly and have replaced older Octreoscan technology because of greater diagnostic accuracy and lower radiation dose. Most SINETs express somatostatin receptors, particularly subtype 2, making them light up on these scans. This functional imaging is absolutely crucial because it shows not just where the primary tumor is, but also identifies all sites of disease throughout your body. You'll also need cross-sectional imaging, either CT or MRI of the abdomen, and liver MR. I may be preferred during follow-up because it's more sensitive for detecting small liver metastases and doesn't expose you to radiation repeatedly. If somatostatin receptor imaging shows thoracic lesions, you'll need a CT chest as well. Now, here's something important. If you have carcinoid syndrome symptoms, echocardiography should be routinely performed to rule out carcinoid heart disease before any surgical intervention. Carcinoid heart disease affects right-sided heart valves and can develop in patients with elevated serotonin levels over time. Surgery remains the cornerstone of potentially curative treatment for SINET. For localized resectable SINET, the surgical gold standard includes an open approach with bimanual palpation of the entire small intestine and a vessel-sparing lymphadenectomy. That means removing at least 8 lymph nodes while preserving as much of your blood vessels and bowel as possible. This isn't the old pizza pie approach that removed large sections of intestine. Modern technique uses a retrograde vessel-sparing lymphadenectomy that has been shown to shorten the resected bowel specimen by about half compared to older techniques. Why does this matter to you? Because preserving bowel length prevents short bowel syndrome, a serious complication where you don't have enough functioning intestine to absorb nutrients properly. Even if you already have liver metastases, surgery on the primary tumor and mesenteric disease can provide significant benefits. In experienced centers, a complete resection of the primary tumor and regional mesenteric nodal metastases can be achieved in up to 80% of cases. Following curative resection, there's no evidence supporting adjuvant therapy, meaning you won't need chemotherapy or radiation after surgery if the tumor is completely removed. Now there's ongoing debate about prophylactic cholecystectomy. Recent evidence shows that on-demand surgery can be considered non-inferior to prophylactic cholecystectomy, meaning your surgeon might choose to leave your gallbladder if it's healthy and only remove it later if gallstones develop. Current evidence supports follow-up only, but this needs to continue for a long time because disease relapse can occur even 15 years after surgery. For patients with mesenteric fibrosis causing symptoms like bowel obstruction, surgery remains the treatment of choice despite the technical challenges. If you have advanced unresectable SINET, let's talk about your treatment options in the order they're typically used. First-line treatment is almost always somatostatin analogues, either octreotide LAR or lanreotide autogel. These are monthly injections that work in 2 ways. They control hormonal symptoms if you have carcinoid syndrome, and they slow tumor growth. The PROMID and Clarinet trials demonstrated significant prolongation of progression-free survival compared to placebo. These medications are generally well tolerated, though you might experience gastrointestinal side effects early on, some nausea, diarrhea, or abdominal pain that usually improves. Now, if your disease progresses on somatostatin analogues, the next standard treatment is peptide receptor radionuclide therapy, or PRRT. This involves lutetium-177 dotatate, a radioactive treatment that binds to the somatostatin receptors on your tumor cells and delivers targeted radiation. The landmark NETTER-1 trial showed remarkable results. Patients randomized to 4 cycles of Lu-177 dotatate combined with octreotide had a median progression-free survival exceeding 28 months compared to just 8.4 months with high-dose octreotide alone. The hazard ratio was 0.21, meaning PRRT reduced the risk of progression by nearly 80%. This was associated with improved quality of life, with significant benefits in global health, physical function, and role function, plus symptomatic benefits for diarrhea, pain, and fatigue. The main concern with PRRT is the potential for myelodysplastic syndrome, a bone marrow disorder, which occurred in about 2% of patients in long-term follow-up. Renal side effects may occur, but are usually mild. For patients whose tumors don't express somatostatin receptors or after PRRT failure, everolimus is an option. This is an oral medication that inhibits the mTOR pathway involved in cell growth. If your disease is predominantly in the liver, there are specific liver-directed therapies to consider. In highly selected patients with resectable liver metastases, surgical resection can be performed, particularly for patients with functioning tumors, where debulking 70% to 90% of visible disease can provide both symptomatic relief and potentially survival benefit. Percutaneous ablation using radiofrequency ablation can treat isolated metastases either alone or in combination with surgical resection. For patients with liver-predominant disease and hormonal symptoms not controlled by medical therapy, transarterial embolization options exist: bland embolization, chemoembolization, or radioembolization. So here's your bottom line. Let's talk about the 4 categories of action you can take based on where you are in your journey. If you've just been diagnosed, insist on evaluation at a specialized center with a multidisciplinary team experienced in neuroendocrine tumors. The European Neuroendocrine Tumor Society recommends referral to ENETS centers of excellence or centers of high expertise. This isn't being demanding. It's essential because these are rare tumors requiring specific surgical techniques and treatment protocols that general oncologists might not encounter regularly. Get complete biochemical assessment, including chromogranin A and urinary 5-HIAA measurements. Before the 5-HIAA test, avoid serotonin-rich foods for 24 hours, specifically bananas, avocados, walnuts, pineapple, plums, and certain nuts. Ask specifically, will you perform bimanual palpation of my entire small intestine to look for multiple tumors? Remember, 40% to 60% of patients have multiple synchronous tumors not visible on scans. Ask about the lymphadenectomy plan. Will you retrieve at least 8 lymph nodes? Studies show adequate lymphadenectomy should include at least this number for proper staging. Ask, what technique will you use? Vessel-sparing lymphadenectomy or traditional resection? The newer technique preserves more bowel length. If you have liver metastases, ask, am I a candidate for simultaneous liver resection or ablation? If you're starting somatostatin analogues, understand you'll receive either octreotide LAR 30 mg monthly or lanreotide autogel 120 mg monthly. Treatment continues indefinitely until progression. You may develop gallstones as a side effect. This occurs because these medications affect bile composition, but prophylactic gallbladder removal isn't routinely recommended anymore. Expect regular monitoring every 3 to 6 months initially, with cross-sectional imaging. For NETG1 patients, this might be every 6 months. For NETG2, every 3 months. After 3 to 5 years of stable disease, intervals can be prolonged to 12 months. Contact your medical team immediately if you develop severe abdominal pain, persistent vomiting, or signs of bowel obstruction. These could indicate mesenteric fibrosis complications requiring urgent surgical evaluation. If you're on somatostatin analogues and experience worsening diarrhea or flushing despite treatment, this might indicate inadequate hormonal control, requiring dose adjustment. Watch for signs of carcinoid heart disease, shortness of breath with exertion, leg swelling, or exercise intolerance. Annual echocardiography is recommended in patients with carcinoid syndrome. If imaging shows disease progression on first-line treatment, discuss PRRT as a type of targeted radiation therapy used to treat certain cancers, particularly neuroendocrine tumors. Timing with your oncologist. The NETTER-1 trial showed maximum benefit when used as second-line therapy in progressive disease, but the NETTER-2 trial suggests it might be appropriate earlier in selected patients with higher-grade tumors. For patients with Ki-67 above 10% showing rapid progression, discuss whether more aggressive treatments like PRRT or everolimus should be considered as first-line rather than somatostatin analogues alone. Small intestine NETs are often found late because of subtle symptoms and diagnostic challenges, but once properly diagnosed and staged, they're highly treatable with surgery as the cornerstone for localized disease and excellent long-term outcomes, even with metastatic disease through sequenced systemic therapies. Your next step, ensure you're being evaluated at a specialized NET center and get comprehensive staging, including both somatostatin receptor PET imaging and biochemical markers, before finalizing any treatment plan. This information is for education. Always discuss your individual situation with your healthcare provider. I've outlined several reputable resources here, which you may find valuable for further information on this topic. These include the European Neuroendocrine Tumor Society 2024 guidance paper for management of well-differentiated small intestine neuroendocrine tumors, published in the Journal of Neuroendocrinology, the ENETS Consensus Guidelines for Surgical Treatment, the ENETS Guidance on Carcinoid Syndrome and Carcinoid Heart Disease, and the ENETS Standards for Follow-up and Documentation. All links are available in the description below. Thank you for watching.